Good morning. This is Gary Greenswag, and welcome to Grand Rounds this morning. We have a great speaker and list of panelists. We're going to talk about adult depression screening and treatment. And I would just say, in terms of introductory remarks, that today is September 29th, and we are completing a flurry of activity around suicide prevention in the month of September. I just looked online, and not only was it annual suicide prevention week from September 6th, 10th through the 16th, it was also National Suicide Prevention Month for the entire month of September. And as I think many people know, September 17th was National Physician, and we say National Physician and APP Suicide Awareness Day. And so a lot of activity for September, but this is not a problem just in September. It's a problem throughout the year, and it's a problem certainly as COVID has wound down, that the behavioral health needs of us as a nation and probably as a world have grown, and there is lots of attention and focus on how that affects our patients' well-being, and certainly our role in helping with that. So just like with hepatitis C and COVID and lots of other sort of diseases that we have focused on in clinical standards, there's been a flurry of activity associated with the depression screening goal for children, adolescents, and adults. That is part of CMS and certainly part of what we should be doing. And the one and last comment I'll make is that if I look at the quality and chronic disease management tools and initiatives that we've had since Common Spirit Health started, I think if you look at the QR codes in our behind our speakers, you will find a plethora of information, toolkits, and an amazing amount of work that has gone into supporting clinicians in this process. And we are well aware that finding people, just like with hepatitis C, is the first piece. It's about screening. But then there's the matter of treatment. And so that's what we're here today to sort of get our arms around. We have another Grand Rounds coming up on sort of same process for children and adolescents, and a suicidality identification rounds that will follow, Grand Rounds that will follow that. So with that, I'm going to turn this over to Dr. Sagar, who's going to introduce our panelists and speakers and get us going.
Thank you, Dr. Greenswag. A big welcome to everybody. I know a lot of us have been waiting for this discussion, so let's get started. Our first speaker is Dr. Rajesh Tampi. He is the professor and chairman of the Department of Psychiatry and the inaugural Bhatia Family Endowed Chair in Psychiatry at Creighton University School of Medicine and Catholic Health Initiatives Behavioral Health Services in Omaha. He is also a professor of psychiatry adjunct at Yale School of Medicine in New Haven, Connecticut. And Dr. Tampi is the inaugural historian of the American Association for Geriatric Psychiatry, and he is the past president of the American Association of Geriatric Psychiatry. So quite the stellar resume. I've only given you probably a 1/10 of his CV, and you will quickly find out how impressive his knowledge base is in the talk this morning. We also have on our panel Debra Rockman, who is the System Vice President of Ambulatory Quality for Common Spirit Health. She is a registered nurse with 37 years experience in clinical, educational, quality, and risk aspects of healthcare industry. She received her Bachelor's of Science degree in nursing from the University of Texas Medical Branch and a Master's in Business Administration from Texas Women's University. She's a member of the American Society of Healthcare Risk Management, National Association of Healthcare Quality, and is designated as a certified professional in healthcare risk management and quality. For those of us who have had the opportunity to work with Debra and to see her leadership really, truly blossom in the last few months, it's been an absolute pleasure to see all the wonderful things coming out of ambulatory quality. So thanks, Debra. And we have Dr. Monique Díaz as our second panelist who has completed medical school and a clinical informatics fellowship at the University of Illinois in Chicago and trained in physical medicine rehabilitation at Loyola University Chicago. She currently serves as a CMO for Pacific Central Coast Centers, which runs nearly 50 ambulatory offices. And she serves as the current PE West CMIO. And I will always remember the first conversation I had with Dr. Díaz was, we need to do something about depression. And so I'm so excited to have her back on this panel. With no further ado, I turn it over to you, Dr. Tampi. Welcome.
Thank you. Thank you very much. Good morning, everyone. And thank you, Dr. Greenswag and Dr. Sagar, for that very kind introduction and welcome. And it's my pleasure to be here today to talk about adult depression and screening and management in primary care. I'll give you a gestalt of a very big and important topic. And I think the best part is the discussion that we're going to have and answering questions from our audience. Next slide, please. I have no personal conflicts of interest to disclose for this presentation. Next slide, please. So the objectives are very simple. I'm going to talk about the epidemiology of depression among adults. I'm going to talk about the evidence-based assessment and also then the evidence-based treatment for depression among adults. Next slide, please. So, here are two cases that are very illustrative of a practice in your practice that you might see. One is a person who's a young man with 1 month history of depressive symptoms, no previous psychiatric history, no active medical issues. And when you do a PHQ-9 screen, he scores 10. So this is one case. And the second case is a 55-year-old woman with 5-year history of depressive symptoms, 2-month worsening of depressive symptoms, including poor sleep and 10-pound weight loss. The patient also has comorbid anxiety, hypertension, and hypothyroidism. And when you do the screen with the PHQ-9, the patient scores 15. So the treatments for these two cases will be a little different. And as you go through these slides, you'll realize where we are coming to, and then we'll discuss it at the end as how I would treat these two patients. And like I said, it might be a little different. Next slide, please. Next slide, please. So what we know is that depression is a highly prevalent illness. In the United States, right now, the prevalence for depression among adults is 18.5%. It is highest among the young adult group, which is between 18 and 24 years at 21.5%. And it is the lowest in individuals over the age of 65 years with a prevalence rate of 14.2%. When you compare women with men, women have more depression and major depressive disorder compared to men, and the prevalence rate is 24% in women and 13.3% in men. When you look at prevalence rates based on race, you will see that non-Hispanic whites have the highest prevalence rate of depression at 21.9%. Non-Hispanic Asians have the lowest prevalence rate of depression in the United States at 7.3%. Education is a protective factor for depressive disorders. And this is seen in the recent study, which showed that those individuals with college degrees or higher had the lowest prevalence of depression at 15.4%, whereas those with less than high school education had the highest prevalence at 21.2%. Next slide, please. Why is depression that important? It is the third leading cause of disability worldwide. If you have a patient with depression and they have any medical issue or any surgical issue, if you don't treat the depression along with treating their primary other medical disorder, you will see that the outcomes are worse. So it is very important for us to be cognizant of the fact that depression is common and can occur as a comorbid condition and then can actually worsen all outcomes for all other conditions. So assessment and treatment of depression is a very, very important task for all of us providers. We also know that suicide, which is the 11th leading cause of death in the United States, is associated with depression 50% of the time. So it is important to assess and screen patients for suicidality when they come in for an assessment of depression. And we will talk about some of the evidence-based assessment scales for suicide during this presentation. What we also know is that the depression has a bimodal occurrence. So it occurs in the mid to early 20s, and then there is a second peak that happens in individuals in the 50s possibly due to psychosocial changes and also biological changes, including in women, the onset of menopause. Prognostic indicators. If you have a comorbid condition associated with depression, that worsens the depression outcome, especially if you have coexisting anxiety, and coexisting anxiety occurs in 50% of individuals with depression. Psychotic symptoms associated with a depressive episode is a bad prognostic indicator. Co-occurring or comorbid substance use is a bad prognostic indicator. The presence of borderline personality disorder is a bad prognostic indicator. If the individual has had depression for a longer period of time, that indicates that the depression is more persistent. That is a bad prognostic indicator and may need a higher level or more supervised care. If the patient has greater severity of symptoms, so compared to mild symptoms, if the patient has severe depressive symptoms, that is also a bad prognostic indicator and may also indicate a longer duration of symptoms in some individuals. So remember, comorbidities, when it occurs with depression, indicates bad prognosis, and these are the few comorbid conditions: anxiety, psychotic symptoms, substance use disorder, and borderline personality disorder, which we know really worsen the outcome in these individuals. Next slide, please. Why are we talking about depression, and why treat these conditions in primary care? Majority, that is over 60% of psychiatric care actually occurs in primary care doctor's offices. It takes about 2 to 3 years before a patient will come and see a specialist. People trust primary care physicians, they go to primary care physicians, and they would want their care centered in primary care offices. So even the depression treatment starts in the primary care provider's office in majority of the cases. What we also know is that 79% of prescriptions for any psychiatric condition starts to occur in the primary care doctor's office and are provided by non-psychiatrists. What we also know is that majority of these prescriptions don't have an associated psychiatric diagnosis. So that is why it is important for people to be educated that when you prescribe psychotropic medications, it has to have a specific indication noted along with that. We also know is that among individuals who attempt suicide, 38% visit a healthcare provider within the previous week. So many of these individuals may not come saying that they're depressed, but they may have unexplained medical conditions. They may have somatic symptoms like headaches. They may have body aches, GI problems. But when you actually screen, you may find that these patients are profoundly depressed, but they are not able to enunciate the word depression. So you may have to ask about depression and screen for depression. What we also know is that 64% of healthcare providers 64% of individuals who attempt suicide visit a healthcare provider in the preceding 4 weeks. So it is very, very important to be cognizant that depression is people who come in for unexplained medical conditions can actually have an underlying depression, and we need to screen for depression. And if they screen positive, must ask about suicidal ideation. Next slide, please. What are the risk factors to depression in adults? As you can clearly see, we have social, biological, and psychological risk factors. The important point to remember is the social determinants of health are an important predictor of developing depression in late life. So please ask about how they have access to housing, access to healthcare, access to good water, food, education, because these all do add to the burden of care. And what we know is that individuals in lower socioeconomic strata who are not able to access good healthcare are at much higher risk of depression. We, of course, have the biological risk factors, including age. As we saw, depression is more common in young adults. It is more common in Caucasian race. It runs in families. And as you have more comorbidities, both medical and psychiatric comorbidities, the risk for depression and the risk for more severe depression happens. Certain psychological traits like negative self-talk, sensitivity to rejection, neuroticism, that means people who perseverate, rumination, negative emotionality, all increase the risk of depression. And what we know is that these these risk factors are not just additive, but they are multiplicative. So actually they worsen prognosis if these risk factors occur together. Next slide, please. In an excellent meta-analysis, investigators found that among the convincing evidence of risk factors for developing depression using prospective studies were widowhood, physical abuse in childhood. So early childhood trauma is a big risk factor. Obesity, having 4 or 5 metabolic factors, sexual dysfunction, and job strain are the most important risk factors for developing depression among adults. So I always check these things out when I see a patient, because these are the individuals who are at higher risk of developing depression, even if they're coming for another psychiatric condition that they're being evaluated for. Next slide, please. So we talked about depression. So how do you diagnose somebody with a major depressive disorder? So the DSM-5 indicates that major depressive disorder can be diagnosed in an individual if they have 5 of the following 9 symptoms that is present every day during a same 2-week period as reported by the patient or observed by others. So the 9 symptoms, you need 5 of those to meet the criteria for a major depressive disorder are low mood, anhedonia, that is decreased interest or pleasure in activities, insomnia or hypersomnia, fatigue or loss of energy, significant weight changes, that is more than 5 pounds either gain or loss, psychomotor agitation or retardation, indecisiveness or poor concentration, feelings of worthlessness or inappropriate guilt, recurrent thoughts of death, suicidal ideation with or without a specific plan. And for you to meet the criteria for a major depressive disorder, either 1 or 2, low mood or anhedonia, should be present. When you look at the PHQ-2 and the PHQ-9 screening tools, these are the questions that you're going to be asking. What also should happen with all these symptoms being present, there should be a change from a previous level of functioning, an impairment in psychosocial functioning with the presence of these symptoms. And these symptoms should not be due to a medical disorder or a comorbid psychiatric disorder or due to a substance use. And when we look at the differential diagnosis, I will point this out again. And if the patient has a manic episode, that means the patient has a bipolar 1 disorder and the current episode is depressed. If the patient has a history of hypomanic episode, then the patient has had a bipolar 2 diagnosis and is currently in a depressive episode. So this is how you diagnose major depressive disorder according to the DSM-5. Next slide, please. We can also differentiate the severity of the major depressive disorder. If the patient has some symptoms, but is manageable, and there is no significant functioning decline, that is a mild depressive episode. If the patient has more symptoms, moderate level of impairment of functioning, that is a moderate episode of depression. If the patient has significant number of symptoms, has significant distress, and there is a significant decline in psychosocial functioning, then that is a more severe episode. And as I pointed out, more severe depressive episode usually tends to last longer. So you need to pay attention and you may need to refer the patient to a specialist for further treatment. Next slide, please. So how do you assess a person who's coming in for a depressive episode? You have to get a comprehensive psychiatric history. You have to do a comprehensive medical history because many individuals, especially middle-aged and older adults, may have comorbid medical conditions that may actually be presenting as a depressive episode. You have to do a physical examination because you want to rule out those comorbid conditions that could be mimicking a depressive episode. You have to do the lab test to rule out those medical disorders, and you have to use screening tools to both assess the type and severity of symptoms. Next slide, please. So what does a comprehensive history include? You have to look at the duration of the episode. Like I said, usually more persistent depression is usually more severe. You have to look at the current symptomatology. Like if you remember the first cases, one young person, no symptoms other than depression, middle-aged individual, longer duration of illness, recurrent episodes, not eating well, weight loss, and sleep problems. So you have to see what kinds of symptoms are presenting. So the treatments may be a little different. You need to look at impact on functioning. If the patient's functioning is severely impaired, then the patient is in a more depressive episode and has a worse prognosis. So we may need to pay more closer attention, and we need a referral to a specialist. History of previous episodes. Usually the first episode is followed in 50% of the cases with a second episode within 1 year. So you need to see how many episodes are happening, because if a patient has only one episode, you may be able to try an antidepressant. When the patient's symptoms are in remission, you may be able to taper off and discontinue the medication. But if the patient has had multiple episodes, and the data is that if you've had more than 3 episodes of depression, the patient may need to stay on the antidepressant medication lifelong. So getting well is the staying well dose. And if you have had more than 3 episodes, you may need to be on it for a longer period of time. You need to assess for substance use disorders, because as we saw in the previous slides, substance use disorder or any comorbidity worsens outcomes in these individuals. You also need to know about response to treatments. If the patient has failed a good trial of a particular antidepressant in the previous episode, retrying that medication probably is not the best thing to do. You may need to you choose a different class of medication. You also need to know about the family history of depression, family history of suicides or alcohol abuse, because individuals with family history have greater risk of developing depression, greater risk of developing comorbidities as it runs in the family. You may need to know the psychosocial context of stressors, because many of these individuals have multiple psychosocial stressors. If you don't address the psychosocial stressors, no amount of antidepressant or other treatments is going to help, because the stress is still there, which will worsen outcomes. You may sometimes have to get collateral information from the family or caregivers, because the patient may not themselves say that they're depressed or may not give the correct information. So you may need to get collateral information to assess assess and make a diagnosis, and also assess the severity and comorbid conditions that may be existing. Next slide, please. So I'm preaching to the choir, but I will just state this again because it is so important. You always have to work up medical issues that are happening with a patient. 1/3 of individuals who present with depression have comorbid medical conditions that are impacting or worsening the depressive symptoms. These include ruling out common conditions like anemia, hypothyroidism, seizure disorder, Parkinson's disease, sleep apnea, vitamin deficiencies, especially vitamin B12 and folic acid. And also you have to rule out infectious etiology, like HIV, syphilis, or Lyme disease. Nowadays, you may need to rule out long COVID, because many of these individuals present with profound depressive symptoms which are prolonged. So you have to do a good medical workup before you start prescribing psychotropic medications. Next slide, please. What additional studies would I recommend? And this is mainly if the patient is middle-aged or older, an EKG, especially if the patient has a previous cardiac history. You're looking mainly for bradycardia, because you don't want to give medications that can cause bradycardia, especially the tricyclic antidepressants. You don't want to give medications that can cause QT prolongation, especially antidepressant like citalopram. Many patients, in my practice, we see at least 20 to 25% of our patients have comorbid sleep apnea, which nobody has treated. So you order a polysomnography, because these individuals have multiple sleep disorders. So you may need to treat that first, because without treating those conditions, the treatment of depression may not be adequate. In certain situations, you may need to do an MRI when you suspect cerebral vascular disease, especially in individuals with a previous history of TIA or strokes. You may need to do psychological or neuropsychological testing when a patient presents with personality disorders, and because they impact the outcome. You may need to do neuropsychological testing to see if the patient has an underlying neurocognitive disorder, because we know that depression is highly comorbid in individuals with dementia. So you may need to do those additional tests if the patient is older and presenting with additional symptoms. Next slide, please. So what about universal screening for depression and suicidality. The US Preventative Services Task Force states that there is good evidence to screen for depression among adults, including pregnant and postpartum individuals, and among older adults. But the evidence for screening everyone for suicidality is limited by the amount of data. So they recommend universal screening for depression, not suicidality. But if the patient screens positive for depression, you absolutely must screen for suicidality. Next slide, please. So what is the best screening tool that you can use for screening for depression in primary care offices? The PHQ-2 is actually a good screening tool. And as I said before, if you look at the first two questions of PHQ-2, they are from the DSM-5 diagnosis. Little interest or pleasure in doing things, that is anhedonia, and feeling down or depressed, that means depressed mood. The scale goes from 0, that is not at all, to nearly every day, which is a 3. And if you add the scores, if the patient has a score of 3 or more, you need to do one of the two things. Administer a full PHQ-9 to see how severe the depression episode is, or do a good assessment for a major depressive disorder. So PHQ-2 is what I would recommend for initial screen for depressive symptoms. Next slide, please. If you look at the PHQ-9, which is the longer version of the PHQ, it has all the 9 symptoms. And remember, if you need 5 of the 9 symptoms to meet the criteria for a major depressive episode, this particular scale also goes from 0, which is not at all, to nearly every day, to a 3. It also looks at the severity of the symptoms with no difficulty in functioning, somewhat difficulty in functioning, very difficult functioning, and extremely difficult functioning. And you can actually rate the severity of the depressive episode based on the scores you get. 0 to 4, the patient has minimal symptoms. 5 to 9, mild depressive episode. 10 to 14, moderate depressive episode. 15 to 19, moderately severe. And 20 to 27, severe depressive episode. Next slide, please. We cannot talk about depression without talking about suicides. As I pointed out earlier, it is the 11th leading cause of death in the United States. The prevalence is about 14.4 per 100,000. And what we know is that women attempt suicide more than men. And the risk ratio is 1.33 to 1, women compared to men. But men die of suicide almost 4 times more than women. White men, remember again, race makes a difference in this. White men account for 70% of all suicide deaths. Firearms, especially in the United States, are involved in 55% of all suicide deaths. The rates of suicide are highest among 85-year-old individuals. That is 22.39 per 100,000. So if you have an older Caucasian man who is isolated, who has a lot of medical issues, who has severe pain, acute and chronic pain, that is a patient you will have to screen very closely and monitor very closely for suicidal attempt and completed suicide. So that is the risk profile that you have to do, and you may need higher level of care for the individual that I described. When you look at age-adjusted, when you look at highest suicide risk in based on race, Caucasians have the highest suicide rates of 15.65 per 100,000. Asians and Pacific Islanders have the lowest at 6.86 per 100,000. Next slide, please. So there is an excellent meta-analysis looking at risk factors for suicide. So the risk factors for suicide attempts versus completed suicides are a little different from each other. So for risk factors for suicide attempt, the highest risk is previous attempt. What we know is that 1% of every person who tries to commit suicide kills themselves at the end of 1 year. 10% of all individuals who try to commit suicide die of suicide at the end of 10 years. So that is the risk factor. Family history is the second most common risk factor for suicide attempt. Internalizing factors, where people are introspective or they keep things to themselves, that is the third most risk factor. Treatment history, previous history of treatment, indicates that the patient probably has more severe depressive episode is a risk factor, followed by social factors. That is, these are the top five risks for suicide attempts. When you look at suicide completion, previous treatment history is the biggest risk. So people with previous depressive episodes, previous treatment for depression and anxiety or for schizophrenia, they are the ones who are going to complete suicide, followed by those individuals with family history. So the genetic loading, that means they have more severe depressive episodes, are at higher risk. General psychopathology, that means more severe symptoms, more the risk of completing suicide. Previous attempts, so 1% die at the end of 1 year, 10% die at the end of 10 years. Social factors, people who are single, people who are homeless, people who have limited access to healthcare, limited access to food, and all of these insecurities increase the risk of completed suicide. Next slide, please. So when you look at mental health disorders, the highest risk of suicides for both men and women is for major depressive disorder, followed by bipolar disorder, especially during the depressive episode, followed by schizophrenia, followed by anxiety disorders, followed by dysthymia. So these are the top 5 mental health disorders in risk for suicide for both men and women. Next slide, please. So what are the evidence-based screening tools that we can use in primary care? There is the Ask Suicide screening tool, which has 5 questions. The first 4 ask about thoughts of killing yourself, and the 5th one asks about thoughts of imminent risk of death. So if the patient scores positive on any of the top 4, you have to ask the 5th question. And if the patient scores positive on the 5th question, you have to make sure that the patient is safe. Do not leave the patient alone. Keep the patient in your eyesight. Get help. Do a full assessment. They may need high level of care. If the patient does not meet the criteria for high suicide risk, then you need to treatment plan for how they can get outpatient treatment and what kind of follow-up they can get. We use the Columbia Suicide Severity Rating Scale, the CSSR. I like the triage version, but because it gives you immediate risk. It has 6 questions. The first 2 questions screen for suicide risk. If the patient is positive on the second question, you ask all the questions to make sure that the risk stratification is done. If the patient does not answer positive on the question number 2, you still ask question number 6 to see if the patient has a previous history. If the patient scores positive on all, that is a high or imminent suicide risk, and that person needs probably inpatient level of care. Do not leave the patient alone. You have to monitor them till you take them to the next highest level of care. Next slide, please. So we've talked about evidence for screening based on the U.S. preventative services. We also know in a recent meta-analysis, this was proven that universal screening for depression is indicated, but universal screening for suicidality is not indicated based on limited data. But if the patient screens positive for depression, you have to screen for suicidal risk also. Next slide, please. So what about the differential diagnosis? A very quick overview. You have to rule out bipolar 1 and bipolar 2. If the patient has had a manic episode, it is bipolar 1. If the patient has had a hypomanic episode, it's bipolar 2. Rule out medical causes for depressive symptoms, like I said before. Common things, if the patient has hypothyroidism, the patient has anemia, the patient has other metabolic conditions, you rule and treat those before you embark upon treating the depressive episode. Rule out substances of abuse that can cause depressive symptoms. Rule out persistent depressive symptoms, that is dysthymia, because the patient can have double depression. That means the patient has a major depressive episode along with a comorbid dysthymia, and outcomes are worse for these individuals. Premenstrual dysphoric disorder, especially in women during childbearing age, is very, very important to screen out, because the treatment for PMDD is different from treatment of the depressive major depressive episode. Next slide, please. So what are the aims for treatment? We want to reduce symptoms. We want to reduce suicidality. We want to prevent relapses and recurrences. We want to improve cognition and functioning, and we want to help the patient develop skills so that they can work on preventing the depression from happening. Next slide, please. So there are three main phases when you treat depression. The first 6 to 12 weeks is the acute phase. We are starting a treatment, we are titrating up, we are monitoring for side effects, and we are seeing if the patient has a response or remission. Remission means total absence of symptoms of the depressive symptoms. And response means the patient has some improvement, but they have not reached the criteria for remission. Once the patient is in remission, then that is the continuation phase for the next 4 to 9 months, when you are making minor adjustments in treatment to keep the patient stable. Once the patient reaches about 9 to 12 months, you're looking at maintenance treatment. Remember, I said getting well is the staying well dose. If the patient has had more than 3 episodes of depression, the patient is probably going to be on an antidepressant medication or therapy lifelong, because the risk of recurrence is very, very high, up to 97% in those individuals. Next slide, please. What are the treatment methods? I'm going to talk about the first 4 because the ketamine, TMS, and ECT are mainly for specialists. And if you ever have a question, you can always email me, and I'm happy to answer questions on those. But we will talk about the top 3. First and foremost, remove things that can actually cause and worsen the depressive episodes, including psychosocial issues, including comorbid medical conditions, and substances of abuse. Psychotherapy is an evidence-based treatment which we can use for all stages of depression, mild, moderate, and severe. You then have antidepressants and augmenting agents. And then you have a combination of psychotherapy, antidepressants, augmenting agents, and those things together, which can help improve depression, especially in more severe depressive episodes. Next slide, please. What about psychotherapy? There is an excellent meta-analysis done a couple of years ago, which showed that active psychotherapy, including cognitive behavior therapy, behavioral activation therapy, problem-solving therapy, third wave therapies. These are therapies which includes modalities of different kinds of therapies, interpersonal psychotherapy, psychodynamic psychotherapy, counseling, and life review therapy, all showed benefit in improving response and remission, with behavioral activation therapy showing the highest rates of remission at 8.6%. So psychotherapy is very much indicated in the treatment of depression in adults. Next slide, please. Now, these are all the medications. I'm sure you've heard about all of those. The SSRIs, that is selective serotonin reuptake inhibitors, include citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. When you look at SNRIs, that is serotonin norepinephrine reuptake inhibitors, desvenlafaxine, levomenacepran, venlafaxine are the 3 drugs in that class. Others are atypical antidepressants include bupropion, mirtazapine, nefazodone, which we don't use anymore, trazodone, vilazodone, voxeartine, and then we have the anxiolytic, which we can combine with these medications, is buspirone. Next slide, please. You can read the slides. The antidepressants are fairly safe. The only one caveat is citalopram has now been given an FDA boxed warning for QTc prolongation above the dose of 40 milligrams in adults and above the dose of 20 milligrams in older adults. Next slide, please. So what about efficacy and acceptability of these antidepressants? When you look at efficacy, you are comparing, sorry about that. You're comparing apples to apples. So the efficacy is the same for most of these antidepressants. So don't let anybody tell you that the efficacy of these drugs is different. So they are almost the same. It is a side effect profile that determines how the antidepressants are being given. So if you look at the side effect profile, the tricyclic antidepressants have the worst side effect profile, so they are not first-line treatment. So it is not the efficacy that determines the prescription. It is the side effect profile in majority of the cases that determines the prescription pattern. Next slide, please. So what is treatment resistance? Patients may not respond to the first antidepressant that you give. The evidence is that 70% of individuals do not have a full response to the antidepressant or remission of symptoms. Only 30% have it. So in those kind of situations, you may need to try different classes of antidepressants. What we call as treatment-resistant depression is individuals who have failed two antidepressant treatments of different classes. So there are levels of resistance. Level 1 is when you have failed one class. Level 2 is when you failed two classes. So for example, SSRIs and SNRIs. Level 3 resistance is when you have failed two of the above classes plus tricyclic antidepressants. Level 4 resistance is when you have failed the other two plus the tricyclics and you failed an MAOI. Stage 4 resistance is what we call as treatment refractory depression. These are individuals who have failed all antidepressant classes plus ECT. So that is treatment refractory depression. Whereas treatment resistance is when you have failed two separate classes of antidepressants. What can we do in these individuals? We can either augment. Augmentation means you're using a compound which is not an antidepressant, and the evidence is best for aripiprazole or Abilify for augmenting antidepressants, or lithium, which is a mood stabilizer. So there is a difference between augmentation versus combination. Next slide, please. So combination. Combination means that you're combining two different classes of antidepressants. So a recent meta-analysis showed that there is good evidence to combine antidepressants, especially the monoamine antidepressants, the SSRIs, the SNRIs, and tricyclic with antidepressants like mirtazapine, which is an atypical antidepressant, or trazodone, which is an atypical antidepressant. So combining may actually give benefit, especially in individuals with treatment-resistant depression. Next slide, please. So how about guidelines for treating major depression? I have put two guidelines. The first one is the American Psychiatric Association guideline, which is about 13 years old. It's a little different from the American College of Physicians guideline, which is more recent. The APA guideline says for mild to moderate depression, you can use either psychotherapy or medication, or you can combine these two, especially if the person has a personality disorder. And in certain patients, you can use electroconvulsive therapy, especially if the patient has, if the patient is pregnant or has more, medical comorbidities, then ECT would be something that you could use. For more severe depressive episodes, those individuals without psychotic symptoms, you use pharmacotherapy. You may not use psychotherapy alone, but you can combine psychotherapy and pharmacotherapy, and ECT is a very viable treatment. When you see patients with psychotic symptoms in severe depressive episode, it's antidepressant plus an antipsychotic. You may use psychotherapy in combination with the treatments, not by itself. And absolutely, you can use ECT in those situations because it might produce rapid resolution of symptoms. Next slide, please. What does the American College of Physicians guidelines say? It's a little different. They say that for mild depressive episode, you just use CBT as your first line. For moderate to severe depressive episode, they indicate either an CBT or a second-generation antidepressant. If they don't respond, you can combine CBT with a second-generation antidepressant. When they say second generation, they're talking about SSRIs and SNRIs. What happens when there is an inadequate response to the initial antidepressant trial? You can switch the antidepressant or augment the antidepressant with CBT. If that doesn't work, then you can switch the antidepressant and combine with an antidepressant, or that means augment with another medication. So that is a little different from the American Psychiatric Association guidelines, but both are evidence-based guidelines. Next slide, please. So this is a more elaborate algorithm. This is mainly for psychiatrists or those of you who are interested more in assessing and treating these depressive episodes. But I think when you come to this stage, I think the best bet is to refer to a mental health provider who can sort of work the patient up and treat them further. Next slide, please. So thank you very much for listening. So I will talk about how I would treat those two cases. For the young man who has no comorbidities and has a first depressive episode, I would probably use an SSRI medication. And I prefer to use sertraline and escitalopram because they have the cleanest drug-drug interaction profile. So that is what I would use for the first person. For the 55-year-old woman with comorbidities, I would make sure that I am ruling out medical disorders, especially hypothyroidism. And if the patient is adequately treated, if not treated, I would ask my primary care colleague to treat them. And I would then decide on an antidepressant, and depending upon the patient's history. Because the patient is not eating and sleeping well, mirtazapine would be my go-to drug. If the patient has tried and failed that, then I would use another antidepressant like fluoxetine and combine with trazodone and refer the patient to a dietitian who can help with improving the patient's weight. So it's a little different in case-by-case scenarios. And I think now we can have our panel discussion. Thank you very much.
Okay, I think we can open it up to panel. Fabulous. Thank you so much, Dr. Tampi. I know we have a couple of questions in the audience. Before we jump into those questions, I wanted to first welcome both Dr. Díaz as well as Debra Rockman to the panel. Dr. Greenswag, I didn't know if you wanted to start off with some questions you may have for Dr. Díaz or Debra to walk through a little bit of the work they have been doing in the background.
Why don't we, thank you. And Dr. Tampi, thank you. That was great. How about if we start with Dr. Díaz and Debra first, and then we'll kind of round around to our questions.
Perfect. Excellent. So Dr. Díaz, I know that you and I have had a conversation previously around the importance of assessing for depression and screening and managing. We just wanted to get to hear your end of it, right? From the perspective of both a physician, a CMIO, a leader. What are your thoughts around this?
Yeah, there's a lot to that, and I did see a question in the Q&A saying, how are we going to get this work done? And that's something I have to speak to a lot, obviously. First of all, when I hear that, it's often a primary care provider who feels very alone in this effort. And I think that's really unfortunate because these are our patients and we all need to start thinking about them holistically. And I like to say, as a specialist, we now have tools at the point of care that even I, feel like I can contribute to this effort, but there's, all joking aside, there's a lot of truth to that. I recently had a patient who wasn't making the progress we had hoped for after her stroke. And, with this effort on my mind, I decided to screen her for depression. And lo and behold, she had a very high PHQ-9 score. And it became clear that her cognition and her movement were being suppressed by poor mental health. And, Dr. Tampi, she had a full medical workup, so I didn't need to do that part. I was fortunate there. But I felt comfortable starting her on an antidepressant and getting her in to see a therapist and even just following up with me. She's doing a lot better now. And so, far from being a task that's eating up my time, detecting depression is really integral to comprehensive patient care. So I think that if we can sort of evangelize that point of view, people won't always feel like, oh, it's all on me to detect this and to do that full assessment and workup. So I really come, from that angle as a specialist. I want to get the word out there, but also from the informatics side, we don't want this to be a big cumbersome process. We really do want to remove those friction points that you might encounter as you're doing this work in the EHR. And since this is such a huge priority, I have found that our clinical informatics teams, they've been very receptive and responsive to feedback when it comes to this effort. So please don't suffer in silence. If you're struggling with the depression screening process, please let your local clinical informatics staff know, so that we can try to optimize the process or escalate an issue as needed.
Wonderful. And I think that's a great segue into a lot of the work, Debra, you have been leading under the ambulatory quality. Can you speak to all the work that's been going in to the FY24 goal for screening for depression?
Well, and thank you. And Dr. Tampi, that was an incredible overview for the management piece of that. And and bringing those education opportunities to our providers so that they are more comfortable in managing mild and moderate depression in the primary care setting is truly one of the goals of this work. But as Dr. Sagar suggested, we have actually started the building of tools and resources to support not only our providers, but our clinic teams in launching an initiative to improve depression screening. And we're measuring that for fiscal year 24, as you all know, but also adding on and building on that improvement journey for the following fiscal year to look at that follow-up piece for patients that are screening positive. But to do that, it took, when we talk about, and I think Kelly put this in a chat recently, it takes a village. We have brought a cross-functional group of subject matter experts who have brought to the table incredible tools that everything from doing role play of how to ask the screening questions for our clinic teams to get that comfort level for those that are facilitating in-person screening. And then we've also have, of course, these education opportunities, partnering with Dr. Sagar and her team for our providers, but our community health partnership and making sure that we've got flyers and connections to connect patients that are suffering with depression to community-based resources to help their mental and social well-being. And then we have self-management tools for those individuals. The behavior activation tools, Dr. Tampi, that you mentioned, we've got those in a toolkit. I'm going to make sure that we have that available to those that are participating in the grand rounds today, so that you can peruse those and kind of a cafeteria style selection of those. So we've got a lot of work to do. But I can tell you one thing that we have learned through our experience with hypertension and diabetes is that our providers and our clinic teams have an unwavering commitment to this work. And they truly do consistently go above and beyond in delivering exceptional care. So we got this.
Thank you. And I completely agree with both what you have said. It's a team effort. It's not an individual effort. And I think that's if there's one thing that I want to point out as all of what the team is doing here and my presentation is, this is not a solo flight. This is a flight for everybody together. And we cannot do it without each other's help. And, I completely agree with Dr. Hope's point that, in primary care, you have 15 minutes to assess a patient. How are you going to do all of this? You're not expected to. And, that's the thing, is you have to screen for the important things. Hey, do you use alcohol? Do you use drugs? Do you have any active medical issues like diabetes that you're not treating? Are you, do the PHQ-2 to screen for depression? And then say, okay, what other medications have you tried that you have helped? Start that, and then you say, okay, this is more severe. Now I need to use my behavioral health colleague to assess that. So I think you're doing the first step of initiating. So your colleague can actually build, and we do it all the time, where we build, okay, your primary care doctor has started your Lexapro 10 milligrams, let's increase it to 20 and see how you do, and take it from there. So I think we have to stand on the shoulders of giants, and we stand on each other's shoulders so that we improve our patient care. And the question of why they don't advocate both the meta-analysis and the US preventative task forces, because there are lots of gaps. There is clear evidence, strong evidence that depression can be screened in primary care, but not all patients with depression are suicidal. So, if you screen a lot of positive things, you'll have a lot of patients sitting in the emergency rooms and admitted to hospitals for no reason. So there are still gaps. That's why they don't recommend screening for suicide for every patient. But if the patient screens positive, then you absolutely need to do a suicide risk screening. So it's a step process in those. What about the suicide risk in healthcare professionals? Depressive risk in healthcare professionals is 2 times the general population. So it is very high.
And Dr. Tampi, just to clarify, your recommendation for a complete psychiatric assessment is following the screening, PHQ-2, PHQ-9, or prior to the screening?
No, if you do the PHQ-2 and it's positive, then you can do 2 things. One, you can do the PHQ-9 if the patient scores positive and more severe. I think you need to refer out to the psychiatrist. You definitely can start treatment. That doesn't mean you shouldn't start the medication or psychotherapy and then say, hey, you know what, I think there are more comorbid conditions, including, personality disorder or substance use. Can you help me with that? So you're starting the point so there is traction is not lost, because the most patients, when they come to the primary care provider, I think that's where you need to get involved and get the treatment provided, because they may not come to a psychiatrist. They may want you to do the treatment.
Right. And so like a lot of things we do, we start we treat their diabetes and say, I'm going to treat your diabetes, but I'd like you to kind of see an endocrinologist to get on the right path. And they're going to tell me what to do, and then we're going to do it. And so I'm sort of hearing that more than I should do the complete.
Correct. Absolutely.
I shouldn't, but I think that's okay. That's very helpful. The other sort of elephant in the room, I think, is it's great if you're in Omaha or in Sacramento or in the Bay Area. Well, and I wouldn't even say that in those places there's lots of behavioral health resources, because I can tell you in California there aren't. But then you could be in rural Nebraska, Fargo, North Dakota, Dickinson, North Dakota, or rural Texas. So we have providers all over the country who really have very little access to. I'd like you to have a check-in with our friendly psychiatrist, but that person could be 300 miles away. And so any thoughts, and I think Debra's comments about, trying to build tools and kind of beef up folks' ability to help with this is really good. But what do you think about just the shortage? We're going to uncover a raft of people who we probably knew about but didn't admit to, but now we know, and our ability to sort of manage that onslaught of patients. I don't know if there's an answer, but it's a worry as we move forward.
Correct. Thank you, Dr. Grinsweig. That is actually a very important point. And like I said, it's a team game. So for me, when I see a patient whose HbA1c is 15, I'm going to address that, because without addressing the elephant in the room, I cannot address any medical condition. So I could talk about, hey, diet, exercise, take your medications, go see your doctor, see a podiatrist, see your ophthalmologist. All those kind of things are part of my discussion planning. What about when you're in a situation where you don't have access to a mental health provider? And I think with telehealth, we have solved 10 or 15% of that issue. But I think the additional 85% needs in collaborative care. You don't necessarily need a person who has gone through psychiatric residency and a fellowship to be able to do that. APPs can be trained and are trained. I mean, some of my best colleagues. I think giving them the right training, making them aware of all the algorithms does help. Another way, I came from Cleveland Clinic here. We had started doing what is called e-consults. I don't need 1 hour to talk to a patient to decide what I'm going to do for this patient. I can read the history and make an assessment and say, okay, you know what, you've tried surgery and it has not worked. Let's think about, augmenting with aripiprazole or lithium, or let's combine with mirtazapine, or let's, refer for esketamine treatment or TMS. I think that's a way of alleviating some of the burden. So you could read 5 charts in an hour and provide the recommendation rather than spending the whole time. So it decreases the burden and the person has immediate access to that resource. I think that's something that, we as a large healthcare system should definitely look into. And you could provide it, the Cleveland Clinic was providing, I think they provide 0.25 RVUs for 15 minutes or, something of that sort, which is equitable. So people don't feel that they're losing revenue doing this.
Yeah. And
those are all options.
Yeah, no, that's great. And we're actually slightly over the hour. That's great. There's been a lot of, I think, interest and comments in the chat. And so I think there's more conversation to have about this. And one thing before closing and thanking you all is to say that I also think we need to look at alternate models of how we deliver this care. Embedded behavioral health folks right in our clinics or, in our markets, so that it's not like, well, you can see a psychiatrist in 120 days that I think they have an opening, but don't miss it because it'll be another 120 days. So I think that we really do need to look at how we deliver care as part of this. But this really was a wonderful morning and a good start for all of the work that has been percolating for the last several months with Debra, Monique, Dr. Sagar, our whole team, Kelly Batonio, and just lots of folks who've been working on this. And we really appreciate, Dr. Tampi, your support, your guidance, your chat with us this morning. And I think this is the beginning, not the end. We're going to be with this for a long time. And I think it's part of what we're trying to do is support our primary care providers, be it hepatitis C, EGFR, all of these things, cancer screening. We really are trying to create some standards that help people and make their life easier, not more difficult. So to the panel, to John and all the folks who put this together, Rachel, who I don't think is on this morning, Ankita, thank you, Debra, for your team, unbelievable, and Dr. Tampi to you. So we hope people have a great rest of the day, great weekend, a safe weekend, lots to think about here.